Welcome, everyone. Thank you for attending our Gutsy Learning Series event on ostomy care in Crohn's and colitis. My name is Emily Decker, the manager of patient and caregiver support at Crohn's and Colitis Canada, and I'll be the moderator for this event. Before we kick things off, let's go over some technical details. If we could advance the slides, please. This session offers audio in both English and French. To access the French audio, click on the interpretation option or the globe icon on the Zoom menu bar and select French language. You can also select to view slides in French by picking the Francais option on the top bar of the screen. If you encounter any technical issues, try refreshing your website browser or restarting the Zoom webinar. Alternatively, you can share your concerns in the Q&A box in the Zoom menu bar, and we will try our best to assist you. Next slide. I'd like to acknowledge the rich history and heritage of Canada's Indigenous people. From coast to coast to coast, we acknowledge the ancestral and unceded territory of the Inuit, Métis, and First Nations peoples who call this land home. Through this acknowledgement, we express respect for the traditional territories of Indigenous communities and contribute to the promotion of reconciliation. Next slide, please. Next, I'd like to issue a disclaimer. The contents of this presentation by Crohn's and Colitis Canada are intended solely for educational purposes. While the information holds general value, it may not be applicable to specific medical situations. Online resources should not be seen as a substitute for the personalized judgment and care by a trained healthcare professional. Crohn's and Colitis Canada does not endorse any external product or service mentioned during this webinar. Next slide. For those of you joining us for the first time, allow me to share Crohn's and Colitis Canada's commitment with you. Our organization is dedicated to discovering a cure for Crohn's disease and ulcerative colitis. Through research, education, awareness, and advocacy, our organization strives to enhance the lives of everyone affected by these chronic diseases. We appreciate your interest in our organization and hope to make a positive impact in the lives of our IBD community. Next slide. We'd like to take a moment to highlight our upcoming Gutsy Learning Series Ask the Expert event on managing symptoms and complications in IBD. You can find the details about the upcoming event listed on the screen here and register for them at crohnsandcolitis.ca/connect-events or by scanning the QR code on the screen. Next slide. If you or someone you know is living with Crohn's disease or ulcerative colitis, we invite you to explore our Crohn's and Colitis Connect platform. This online community offers the opportunity to engage with individuals who understand the challenges of living with inflammatory bowel disease, providing a platform to seek advice and understanding. Next slide. Now, let me introduce our speaker for today's event. We are thrilled to welcome our speaker for our webinar this evening, Teresa Henderson. Right off the top, I would like to thank Teresa for her time today. Teresa is a registered nurse and a certified NSWOC. She has worked in home care, hospital, and ostomy clinic settings for over 37 years. Ostomy care is a passion of hers as she mentors and trains nurses in providing care to people with ostomies. Thank you, Teresa, for being here today to help us raise awareness on this important topic. And Teresa, please take it away from here.
Well, thank you very much for inviting me to speak on this very, very important topic. And as you mentioned, it is a passion of mine for quite a few years now. And now I'm having the opportunity to mentor other nurses. So I hope that goes well also. So to start off with, we're going to start off with a poll question. And basically what it says is, how would you rate your current knowledge of ostomies? From 0, not knowledgeable at all, or 10, extremely knowledgeable. Hopefully that's given everybody enough time. Okay, it looks like everyone is all over the board here tonight, so that's wonderful. Hopefully everyone will gain some knowledge as we go forward. So we'll start the presentation with our agenda, which is the next slide. Thank you. So we're going to start off with what is an ostomy. We're going to go over the initial post-operative assessment after surgery. We'll cover some of the ostomy products that are available, some diet and nutrition, physical activity and what you may wear for physical activity. We'll end with mental and emotional support and then some questions and answers. So the next slide. So what is an ostomy? So an ostomy is a surgical procedure that involves creating an opening in the abdomen to allow for elimination of waste from the body. There are two types of bowel ostomies. The first one is a colostomy, and that is in the large bowel. The second one is an ileostomy, and that is in the small bowel. Take note when you do see your surgeon which ostomy you do have, because unfortunately, when you're speaking with other people, they will tell you, I have the exact same thing as you do, and it may not be, and you might hear the wrong information. So it can be very confusing when speaking to other people. So the next slide. So a colostomy, as I mentioned, is in the large bowel, and it's a surgically created opening on the surface of the abdomen in which a piece of the bowel, large intestine, is brought out to the surface of the skin to create an ostomy, which will allow stool to pass through the stoma. So the surgeon will make an incision in your abdomen, pull a loop of the bowel through the muscle wall, make an incision in the bowel, turn it on itself, and then suture it to your abdomen. So some indications that would cause you to have a colostomy are cancer of the rectum, diverticulitis, congenital anomalies, congenital anomalies, trauma such as gunshot wounds, stabbings, obstruction, and incontinence when you cannot control your bowels. Next slide. So there are different types of colostomies. However, the most common ostomy occurs in the sigmoid colon. Next slide. The second type of ostomy is an ileostomy, and quite often this is for temporary. So it is also the very same as the colostomy, except for it is in a piece of the small intestine, and that is brought out to the surface to create an ostomy, which will allow for the stool to pass through the stoma and into your pouch. Some indications why you would end up with an ileostomy is inflammatory bowel disease, ulcerative colitis, and Crohn's disease, also congenital anomalies, trauma, and familial polyposis, which is when numerous polyps from mainly the large intestine and may become malignant over time. This is typically, next slide, this is typically where the ileostomy will occur. And next slide. So we're going to cover why you would have a temporary versus a permanent ostomy. So a temporary ostomy is usually when you have an ostomy that is 2 months or longer, or a year, up to a year. So basically you're going to be resting the bowel to allow for healing of the anastomosis or the surgical site, such as in an anterior resection procedure. Children with an imperforated anus quite often have a temporary ostomy, which is reversed usually within about 4 months. This is when a child is born with an opening that is blocked or it is missing. And Ontario Ad Health, which is the home care, pays for supplies for approximately 1 month if you have temporary ostomy. And you do not qualify for the assistive device program in Ontario if it is temporary. In converse, for the permanent ostomy, that's quite often the procedure is a resection where you cannot be reattached, or an abdominal perineal resection. Or if for comfort measures, if you are palliative, you would end up with a permanent colostomy, or if your bladder is removed, which you would end up with a urostomy. So it's a stoma that gathers the urine. Funding is also available at the Ontario Health at Home initially, as I mentioned, for 1 month for the supplies. And then for permanent, you can receive in Ontario $975 per year for the Assistive Device Program Ostomy Grant. And people will also use third-party insurance. And sometimes the United Ostomy Association of Canada may assist with funding for children with ostomies, as there is no funding at this time for children with an ostomy. Check with your province, your individual province. I know in British Columbia, there is a mixture of self-pay and pharmacare. And in Prince Edward Island, it depends on your annual income, how much money you would receive. I believe it's up to a maximum of about $675. So when you are going for ostomy surgery, check with your individual province, because every single province is different. Next slide. So some of the factors that we take into consideration when we do a pre-op marking, the surgeon will ask the NSWAC, the nurse specializing in wound ostomy and incontinence, to go and do a pre-op marking before the surgery, mainly because when you're laying on an operating table, everyone's abdomen is flat. So some of the things we'll take into consideration is that we would be placing the mark below the umbilicus or the belly button. Make sure that it's not impinging on your midline. Unfortunately, when you bend over, there's usually a crease on most people, and we want to keep that away from the crease. We want to be going through the rectus muscle. So one of the things that we'll have you do is we'll have you laying down, and we'll have you to raise your head like you're doing a sit-up, so we can measure where the wall of your rectus muscle is, or your abdominal muscle. We'll try and stay away from your belt line. And if you have a rotund abdomen, we'll try and place it in a proper place if you have a larger abdomen. If you have pendulous breasts, we want to keep the stoma away from that so you can actually see the stoma. We take into consideration what you do for a living, so that we can ensure that we're going to be getting the best placement. If you're sitting in a wheelchair, we want to ensure we get it in the best place, so for visibility's sake. Type of ostomy, if you have a ileostomy versus a colostomy, we'll be looking at skin folds, scars, and wounds. If you could, next slide. So post-operative assessment. You can go to thank you. So the initial assessment of the stoma, typically right after surgery, the stoma will be quite swollen. So we'll be looking at the size and the shape of the ostomy, of the stoma. And typically what happens is it takes about 6 weeks for the stoma to get to the size that it actually is going to be. So every time we go to change the appliance, we will be measuring to ensure that it's either has shrunk or perhaps it stayed the same size, but we want to ensure that we get a proper fit. So we're going to look at the color. When it's nice and pink and moist, that's a perfectly healthy stoma. Some people might think that it looks like an open wound, but it's really the same tissue that's in your mouth with mucus on it as opposed to saliva. So when it's pink and it's moist, that's perfectly healthy. We're going to ensure that the sutures around the stoma are present and they're attached, and we never cut the sutures that are around the stoma. They will eventually fall out on their own. And typically I have seen patients up to 6 months and still some of the sutures would be in there, but they will fall out themselves. We look at the peristomal skin, which is the skin that is directly around the stoma, and we'll look for bruising, that the skin's intact, or if it's red, and we will react accordingly. We'll also be looking at the function of the bowel. Typically, what we'll do is we'll listen with our stethoscope to make sure that our bowel sounds present. And it usually functions up from 3 to 6 days post-op. If you have an ileostomy in the small bowel, typically right away you'll start producing some dark green bile type fluid that is coming into the pouch. However, with a colostomy, I have seen patients up to 10 days not pass any stool. And that could be from a lot of analgesic after the surgery, and that you've had your bowel completely cleaned out, and it's taken a long time for you to build up food to pass. So it's not abnormal. So we're going to look at the characteristics and the amount of the effluent or the stool that is produced. And we'll also ensure that there is no leakage. So if you could please forward, thank you. So for the physical assessment, we've brought one really great stoma. If everybody could have a stoma like this, I would not have a job. So for this stoma, it's perfectly round, so we could get a pre-cut appliance on this, no problem. It sticks out about 1/2 inch, and it's in a great placement on the abdomen. The bad stoma, however, it's a little bit inverted, so it doesn't stick out. There's creases where you can see for potential leakage or problem areas, even though the skin does look quite good. So whoever was taking care of it did a great job. This is actually quite flat, and as I mentioned, it would be difficult to pouch. Next slide. So some of the complications for an ileostomy in particular, and mainly for an ileostomy, because the stool is so liquidy and is very, very acidic. So sometimes people will end up, especially at the very beginning, post-op, because we haven't had an opportunity to get the products available to the patient, you may end up with some irritated skin around the stoma. And so this makes it very difficult, especially when you've just gotten out of surgery. You're tired, and this makes you very anxious, especially if you're having any leaking. So sometimes there's narrowing of the tube due to the scar tissue buildup, which sometimes causes a little bit of blockage also. So you may end up with partial or complete blockage due to undigested food. Some ways you'll know that you have this is you'll have some cramping and a little bit of bloating, and you're not passing any stool. Next slide. So managing the complications, what are you going to be watching out for? Every time you will be changing your appliance, you're going to be assessing your skin. It is not normal to have red, irritated, itchy, painful skin. So we'll be looking also at the appliance that you're taking off. I always tell people when you take your wafer off, look at the back, because it will tell you a complete story on what's going on, where it might be leaking. So you're going to be looking for irritation. You're going to be looking also for a peristomal hernia, which sometimes happens around the stoma. I look at both of these pictures, and actually both of these people look as though they have either on the bottom picture, it looks like it's developing around the stoma, and at the top picture, it looks like there is definitely a peristomal hernia. So that is a hernia basically underneath or around the sides of the stoma. There's also something called a prolapse stoma, and that's the one that is at the top. So basically the bowel has come out farther than that perfect stoma we saw before. Sometimes you'll have an improper appliance, either due to gaining or losing weight. And so we have to reassess that every time. And sometimes it may happen a year down the road. But there's always a reason if something's leaking. It should not be leaking, and therefore we need to investigate and get you into a product that is suitable. Sometimes the stoma, for one reason or another, bleeds. It's very fragile tissue to begin with, but sometimes if you're on blood thinners or you're going through chemotherapy or other medication, or if you have this prolapsed stoma and the stoma with friction on the pouch, it may also cause bleeding. So there are ways to address this also. Sometimes people will develop little granulomas. They're little pieces of tissue that are exposed to too much moisture around the stoma, and therefore they can grow with more moisture. So we have to get on top of that and ensure that we're getting a proper seal with no moisture. And I will go over some of the products that we can use for those things also. Sometimes we get stenosis where the bowel has not been brought out far enough, and so therefore we have to stretch the stoma in order to allow stool to be able to be released. Gangrene and necrosis happens next to never. I might have seen one in my entire career, and that is an emergent situation, and chances are you wouldn't be let out of the hospital for that. So, next slide. Some of the strategies and solution to manage some of these complications. So in terms of irritation around the stoma, we're going to determine what the irritant is. Sometimes when you take the appliance off and your skin is completely red, in such as that last picture, I should have actually, you could probably go back to that last picture and then I can address it a little bit better. Thanks very much. So the bottom picture, that is definitely irritation. And I would say 100% that it's an irritation directly related to the appliance. Because when you look at the appliance here, the wafer section, that's exactly where the redness is. So we would determine that you're probably having an allergic reaction to that appliance. And so therefore we would change appliances altogether and ensure we get something that you're not allergic to. For both of these patients with the hernia, there is something called a hernia belt, and it is custom made. There are several different brands out there, but quite often people, especially in jobs where they use their abdomen a lot or they like to do a lot of sports, they will get one proactively before this happens. So basically, once they get their appliance set up at the very beginning, they may go and get measured for a hernia belt, and it is custom made. So the top picture shows the prolapse. And basically what we do, unless it causes you so much grief, which, as long as the stool is passing, the surgeon will not recommend having surgery to revise it. They'll just try and get you to live with it. Some of the ways that you can actually get the prolapse to go back into your abdomen is a cold compress. Sometimes we'll actually sprinkle sugar on the stoma, and that contracts it completely also. And also with the prolapse, there is an accessory binder. So people will have a hernia belt, and then there's a flap that goes over top of the stoma to push keep the prolapse back in. So you can actually massage that prolapse back in. And in proper fitting, basically what we do is we just remeasure and probably either have to cut the stoma. Sometimes if you have a hernia, the stoma will stretch a little bit. And so you'll probably have to go up a size or whatever needs to be according to the measurement. And when the stoma is bleeding or it's rubbing on the pouch and causing friction, some things that we'll suggest is putting baby oil in the pouch in order so that it doesn't cause that friction. Okay, next two slides. Thank you. So we're going to go over some of the Ostomy products, and I do have a few samples here, and there are some pictures on on here. So we're going to start off with the product selection. So what we take into consideration when we see you and we're trying to introduce the products to you, we'll take into consideration whether or not what type of a stoma it is, whether it's an ileostomy or a colostomy. We'll look at your abdominal contours. We'll look at some of the stoma characteristics. Is it perfectly round like that picture that we saw? Or is it oval shape? Is it inverted? So some of the things that we would also use, and also the ability of the individual. I have had patients that are actually blind that have been able to change their own appliance. And we just gear the supplies or the selection of the products to whatever their needs are. So if you had an inverted stoma, like the one picture that we showed, we may use convexity. And this is an example of convexity. Hopefully you can see it. It's an appliance where it's raised at the back so that we can actually push the stoma forward a little bit. And contrary to that, if we had a rounded abdomen, and perhaps you had a hernia, like the pictures we saw, we want something really, really flexible. And there is actually a concave appliance. I didn't have one to show you, but it's a very, very flexible, and it's actually goes the other way over top of the abdomen. It's and also for an ileostomy, quite often it's a very acidic, liquidy stool. So we need something that is very durable. So the backing has to be very durable. So in all of the products, there's an extended wear or there's just a regular wear. So I would absolutely select an extended wear barrier for an ileostomy, just because it does break down the barrier so much. And sometimes you might also need rings to go along with it. Sometimes if you're elderly or you just don't have very good dexterity, I would typically choose a one-piece appliance for people, just so that they didn't have to end up, this is a one-piece appliance here. Everything is all together. Just so that you don't have to snap the pouch on and you don't have to worry about it. And also there's many Velcro closures, such as this one. So that makes it a lot easier for people to be able to close it. So let's go to the next slide. It'll show you a few of the different products that are available. So a one-piece appliance is the appliance that I was showing you. It has a skin barrier, the pouch, and the tape are all attached to it. It's a more flexible option. It doesn't have this hard ring that's on the two-piece appliance. There are convexity options, so that where it is bumped up at the back to allow the stoma to be pushed through. They're available in drainable pouches. And what we mean by drainable is at the bottom, you can drain the pouch. Closed pouch is this type of pouch. And then urostomy pouches, which are for urine. Okay, next slide. So there's also a two-piece pouching system where the skin barrier is separate from the pouch, and the presence of the flange, the part where you snap the pouch on, limits its flexibility, but it makes it a little bit more durable. So the flange and the pouch must match, the sizes must match. And I know that sounds ridiculous, but unfortunately, when you're first starting out with your ostomy, we love to confuse you, and there'll be several different pieces of equipment brought in for you, and you'll start changing it, and you'll end up where the pouch does not hook up, does not match up with the wafer, and you'll be so frustrated. So I know it sounds ridiculous, but that is something that happens. There's also a convexity option, which I showed you here. It's also available in drainable, closed, and urostomy pouches. So next slide. So these are the cut to fit, pre-sized, and moldable. So what I mean when it's cut to fit is you're going to cut it to the size of the stoma. We usually recommend that you cut the opening about an eighth larger than what the actual size of the stoma is. Now, most of the measuring guides that will come in the box, they're all round. So unless you have a perfectly round stoma, you're going to have to measure it out and then cut it to the measurements that you have. So that is the cut to fit option. So when it's not perfectly round and you want to cut it yourself, you can save a few dollars by getting a cut to fit. The next one is a pre-sized, which is exactly what it says. So you say, for example, your stoma was 1 inch, perfectly round. You can purchase a 1 inch appliance that is already pre-cut for you. And the moldable option, you can stretch the opening to the size of your stoma, and then it will actually turtleneck up around the stoma to give a good seal. Next slide. So here's some of the pouches and the closure. So they're all drainable pouches. The first one uses a clip. The second one is more like a Velcro. And then there is also one that's very similar to Velcro. Next slide. This is the closed pouch. And this is typically used for a colostomy because the stool is formed, unlike an ileostomy. So the closed pouch, obviously, once you stool into the pouch, you have to get rid of it. Or there is another option that many, many people use, and it's called a biodegradable liner. And it's right here. So basically, it biodegrades once it gets thrown in the toilet. So it goes into the disposable pouch like this. And then once it's full, you take it out and put it into the garbage. We also have the smaller pouch here. It's called a stoma cap. And a lot of people will use that when they know that, number one, their bowel is empty. And number two, when they're having intimate times, when they're traveling, when you're swimming. So you're pretty sure that your bowel is empty and it's not going to move because the stoma cap does not hold very much at all. And could you move to the next slide? So wear time. It's the period of time the product can be worn before it fails. And ideally, what we want is when you get an appliance, we want you to be in control of when you're changing it, not that it leaks and then that forces you to change it because you'll never gain confidence. So ideally, most people change their appliance about every 5 to 7 days, but you want to be in control of when you're going to be changing it. So it's predictable and it has a sustained wear time. I mean, some people that don't have a lot of financial support end up wearing the appliance longer than recommended. However, if it's not leaking and your skin is perfectly fine, I think that's absolutely whatever works for most people. Next slide. So the barrier durability, that's probably one of the most important things. So if it's resistant to erosion of the barrier for a predictable period of time. So I talked before briefly about the Stomahesive, a standard wear time versus a Durahesive, an extended wear time. Every single company has a barrier that would be for a colostomy where it's not leaking, it's not liquidy stool. And they'll also have an extended wear or a Durahesive, a more durable backing, which you would use for an ileostomy where it is very, very liquid and acidic stool. And all skin barriers are not created equal. However, the nice thing is all of the companies provide samples, so you can try various products. And if one product does not work, do not get frustrated because there will be something that will work for you. Next slide. So we're just going to go over some of the accessory products. When I'm teaching patients how to take care of their stoma, my motto is less is better. However, if you are having leaking issues, these are some of the products that you can use in order to prevent yourself from leaking. Your goal is to get the flattest surface possible. So if there's any creases or anything, you can fill them in with things like the skin barrier paste. So this is not an adhesive, but it's mostly used for caulking. More is not better, and many of these pastes contain alcohol, so it's very drying to your skin and it could become an irritant. However, there are some pastes on the market that do not contain alcohol. And don't apply this type of paste if your skin is excoriated, or it will cause a lot of grief and a lot of pain. Next slide. So the skin wipes, the purpose is to minimize skin stripping due to the adhesives. So it provides a layer of film to the skin so that when you're actually taking off the appliance, you're going to be taking that layer of film off versus your skin. Most of them do contain alcohol, but nowadays every company is coming up with so many amazing products. So you can look around for products that do not contain alcohol. You must also dry the adhesive before you put the appliance on. Dry the skin wipe before you put your wafer on. It's not a skin cleanser by all means, and it's not an adhesive. And for some companies, they do not suggest or recommend you use those products. But if it works for people, then they do it. Next slide. So this is the skin barrier powder that we use. And it's basically used on moist skin. Sometimes you'll develop a moisture underneath the appliance and on skin that's slightly eroded. So it helps to provide a dry surface for the skin barrier to adhere to. Only use a small amount, otherwise it prevents adherence of the flange to your skin, and discontinue the use of the powder after your skin is healed. Next slide. So this is the powder and how to use it and how much. So what we see right now, this is way too much. So what we would do is quite often when somebody has surgery, right after the surgery, right around the stoma needs to heal. So we will add the powder. However, you'd probably want to take off about 3/4 of this powder and just leave a fine film. And this is one example, the stoma adhesive powder that you can use. Next slide. This is skin barrier paste. So you might want to use this as an alternative to the tubes of paste. Sometimes it's a little bit easier to handle, and I have found in my practice it is much more durable. There's no stinging because there's no alcohol in it, and you can break up that strip paste and put it in cracks and crevices, as you see on this picture, where it may be leaking. They're filling in the creases there. We want to ensure that we get the flattest surface possible when we're applying the appliance. Otherwise, it just gives an area where it can leak. Next slide. So we'll just go over a few things with diet and nutrition. Next slide. So we're going to introduce foods really, really slowly. And we're specifically talking about an ileostomy diet. So if you're not a drinker, you might want to start, and I don't mean alcohol, I mean other things, water, juice, clamato juice, things like that. You're going to want to increase your fluids to probably about 10 or 12 glasses a day. You're going to leave out high fiber foods for approximately 6 to 8 weeks after surgery, and then add your high fiber foods one at a time in small amounts. I always suggest to chew your food really, really well and sip fluids all day long. Monitor how your body reacts to new foods. If you're not adjusting well, it's usually indicated by cramping or diarrhea. Some of the things that I will suggest too is preferably don't drink just water. Water will flush out the electrolytes a lot quicker. So if you can have, even Ensure, Boost, Clamato juice, V8 juice, tomato juice, orange juice, Coca-Cola, things like that. All of those things would have a high content of sodium, salt, and potassium. And I know we're always saying don't eat salt, but with an ileostomy, we definitely need salt. We go back to our osmosis. Water goes where salt is, so it'll help to prevent you from dehydrating. There's usually two reasons why people end up going back to the hospital after ileostomy surgery. And the first reason is dehydration. And the second reason is food blockage. Next slide. So some of the high fiber foods that you might want to leave out of your diet, at least for quite a few months, and then just reintroduce them as you can. I have had patients that have had an ileostomy for 10 years, and they eat everything that's on this list now, but it has taken a long time to get there. So some of the things, corn, for some reason, corn ends up back on the cob when it comes out. It doesn't digest very well at all. Raw celery, coconut, Chinese vegetables. Now potatoes, but it's just the skin. You want to leave the skin off because potatoes otherwise mashed are excellent because they're high potassium. And usually you add butter and salt and pepper, so you get your salt in there too. The skins on apples, the skins on grapes, dried fruits will swell, large seed watermelon, raisins swell, etc. Also nuts and the casing on cold cuts, wieners, bologna, mushrooms also swell in your body. Next slide. So some of the things, we're just going to go over fluid and electrolyte imbalance because this is, as I mentioned, one of the reasons why you would end up back in the hospital. So you want to monitor your fluid and electrolyte, your intake and your output as best you can, at least for the first 6 weeks. So in an adult, typically you'll have a dry mouth, your lips are cracked, your tongue is cracked, you can barely form a sentence, dizziness when you're getting up, nausea and vomiting, and sometimes confusion. Monitoring your urine output is a really good indicator because usually when you're emptying your pouch, you probably should be urinating at the same time, and that's usually about 6 times a day. So with an ileostomy. And also if your urine concentration, so the color of your urine gets quite dark, you'll know that you're probably a little bit low on fluids also. Sometimes you'll have sunken eyes, flaccid muscles, muscle cramps, and laziness, lethargy, really, really tired. Unfortunately, in my experience, by the time somebody is completely dehydrated, they can't get anything past their mouth. And so therefore, they end up having to go back to the hospital to get an intravenous to get topped up with some fluids. So that's why it's really important for the potassium and the sodium in your diet. So it'll help to prevent dehydration. For a child, you'll have a depressed fontanelle, so the top of their head will be sunken in, very, very tired and lethargic, sunken eyes, really weak cry, and a decreased frequency of a wet diaper. Next slide. So ideally, we want to prevent this from happening. Sometimes it's easier said than done. You just don't feel like eating. You just don't feel like drinking. But unfortunately, you really have to push yourself. And it's kind of your job post-op is to continue to monitor and keep up with your fluids. So monitor closely your fluid intake and your signs of dehydration, and notify your physician as soon as possible if you're unable to replace the fluids. If you notice you've been busy all day and it's 7 o'clock at night and you think, oh gosh, I haven't drank enough, and you try chugging 5 glasses of whatever you're going to be drinking, it doesn't work that way. Sipping all day long is really, really important. So as I mentioned before, fluids that are high in potassium, V8 juice, Gatorade, orange juice, Coca-Cola, and for sodium, canned soups, and even just a cube of chicken bouillon, you can put that in some hot water and that'll give you tons of salt. Next slide. So sometimes medication, when you're taking medication such as enteric-coated tablets or large tablets or time-release capsules, they may not get absorbed with an ileostomy, depending on where the ileostomy is constructed. So one of the tests to evaluate the breakdown of your medication, place it in a glass of water for a little over 30 minutes. And if the tablet has begun to dissolve, it usually can be adequately absorbed. So don't crush medication unless it's instructed by the pharmacist. And you may need to the physician or pharmacist to order liquid form of medication. Next slide. So physical activity. Next slide. So obviously, like with everyone post-op, exercise with ostomy can speed up your recovery. It certainly helps with mental health, and it strengthens your muscles and core. So preparation for your exercises, be aware of the weakened muscles and do not push it. Avoid lifting heavy objects. Listen to your body and know your limitations, and try and stay hydrated. We can't say that enough. I actually had a patient one time just home post-op about a week, 2 weeks in, and she took her little dog for a walk, and the dog saw a squirrel and pulled on her and stretched the abdomen, and she ended up with a hernia just like that. So you have to be so careful right after surgery. Activities actually such as vacuuming, carrying a laundry basket, standing at the sink doing dishes, put a tremendous stress on your abdomen. So you have to be really careful right after surgery. Next slide. These are just some of the accessory products that really help you get back into being in shape, because it gives you some confidence and support. So this stealth belt, these are both a couple of stealth belts. And one actually, both of these are actually stealth belts. It's just depending on which way you want to put your pouch. The sideways pouch here, I actually have a patient that does body surfing, and she wouldn't be able to do it without this belt. And the other patient that uses the other one, he does a lot of mountain biking. So it's really great to keep everything intact and supportive. Next slide. This is an abdominal binder, and unfortunately it doesn't show the opening, but it would be a custom-made opening for where the appliance would come through. So this is something to consider post-op. It actually helps with healing too. On the other side of the page, we have stoma guards, and this is mostly to provide protection for, say, things like contact sports. If you work in a physically demanding job, I had a patient that was a welder, and he had to lean up against a really hot machine. So the stoma guard was absolutely necessary for him. Next slide. These are just a few pieces of undergarments and a bathing suit to show that there are several different things available. You just have to look, and people are coming up with more and more accessory products, swimwear, things for you to get out and be physically active. Next slide. So the men's trousers, there is a pocket inside. Unfortunately, I don't think it's showing it. And we have another stoma guard, and then we have a pouch that is waterproof for swimming. Next slide. So we are moving on to the mental and emotional support. And these are just some of the supports that are available, but there are so many now. So the Crohn's and Colitis Canada peer support offers a virtual one-on-one support for you and group. And the Crohn's and Colitis Connect has a virtual group support like Reddit, but for inflammatory bowel disease. Also, I know in our area and in many other areas, there's local chapters of support group. So in Oshawa, there's a Durham Association, Ostomy Association, and they meet once a month. Usually bring in guest speakers. Quite often vendors from the companies will come and bring samples. And it is a great support for people. And nurses specializing in wound, ostomy, and continence Canada, that's my role. And this is our website. I have received many contacts via email through NSWAC for patients in our area that are reaching out that had nobody to talk to about an issue. I may end up going to see them at their house, may end up getting them referred to home care, but it's another avenue for you to reach out. Also, your family doctor or your surgeon can refer you in Ontario. It's Ontario Health at Home, and then an NSWAC or a nurse can come out to see you. And all of the companies have care programs and support groups virtually. It's unbelievable some of the programs that are available to everyone. So some of the companies that we deal with, and there's many more, but Coloplast Care has a program. Hollister has the Secure Start program. Convatec has the MC and Service and Care, Salts, and Ostomy Canada. So these are just a few to speak of. And that looks like we're on to the questions and answer.
Awesome. Thank you so much, Teresa. We're now going to move into the question and answer portion of the evening. If anyone has a question, they can comment it in the Q&A box found on the Zoom menu bar. But another reminder, we cannot answer questions about specific medical conditions. And while we wait for those to come in, I've got a couple preset for you, Teresa. The first one is, how long will it take for me to feel confident in managing my ostomy?
Well, fortunately or unfortunately, that's extremely individual response, motivation, support. However, I feel with the proper support and guidance for a new ostomate, I would say a good 6 weeks to maybe a couple of months, you would feel confident and probably independent in caring for the ostomy yourself.
Right then, can I get the next question, please? So, how often should I empty my ostomy pouch, and could this affect my ability to get a full night's sleep?
Well, particularly in the beginning, it would probably keep you up probably at least once or twice a night, and you're going to be paranoid that you're going to leak or it's going to fill up too fast. So in the very beginning, you're probably going to want to get up a couple times a night. But usually during the day, when you're, eating more, you're drinking more, most people would probably empty their pouch probably about 6 times a day. And then once the stoma has been established, you're back to a regular diet. Quite often people will have like cheese and crackers before they go to bed just to kind of absorb some of the liquidy stool. So that will help to kind of keep everything intact, and you probably won't need to get up nearly as often.
Okay, could I get the next one, please?
I should have mentioned also with a colostomy, typically you'll empty it once or maybe twice a day.
A little bit of a different depending on the type.
Depending on the type.
Okay. Are there any dietary recommendations to help ensure I'm getting enough nutrients?
So for an ileostomy, because it is quite different than a colostomy, and you're more at risk for not absorbing certain things. So ensuring you have enough protein, especially post-op, because there is a lot of healing that needs to be done. And also keeping really well hydrated and ensuring that your fluid and electrolytes are kept up. As we mentioned, your sodium and your potassium are your major electrolytes that you need to keep intact. So the things that I mentioned in terms of the fluids that you can have, mashed potatoes have tons of potassium. You're going to add your salt, all the drinks that you're going to have with sodium and potassium, your tomato juice. Tomato juice is the very highest for sodium and potassium. V8 juice, the clamato juice. Those are things that would really help prevent dehydration.
Okay, and then can I get the next one? What advice do you have for managing noise and gas with an ostomy? Are there any specific strategies or products that can help?
Well, it really helps if you have a dog, because you can always blame the dog. I'm just kidding. So what most patients do, peppermint tea actually helps, trying to avoid stressful situations, because that quite often causes your stomach to create a lot of gas. Eating slowly and chewing your food really well. Some of us do that and some of us do not, but that also helps to cut down on gas. Don't chew gum. If you are in a quiet venue, many people will bring a small pillow and they put it up against their stoma, or they'll wear a sweater and they'll put a little something over top of the stoma with their arm, and it'll just muffle the sound of if anything is coming out, or if you're concerned that that's going to happen. But I have patients that have had stomas for years, and it's just one of those things that they bring all the time with them, just to prevent that embarrassment.
Fair. I do like the dog suggestion. Okay, could I get the next one, please? Do you have any tips when it comes to traveling with an ostomy? What about going through airport security?
So what I have learned over the years is some people will actually take a doctor's prescription note through security, and or they will tell the security what they have ahead of time. But usually taking a prescription note from the doctor will help. So because if all of us get patted down from time to time, and they're definitely going to be questioning what the feel of that is, for sure. And definitely when you're traveling, ensure you bring more than enough equipment. Pre-cut your appliances, because you're not going to be allowed to bring scissors onto the airplane. Have an emergency change prepared for when you are on the plane, and research before you go where you can purchase extra supplies. I've actually met people on planes and they were changing their appliance in the bathroom. And I just happened to be the one standing outside waiting to use the restroom. It was quite ironic, but anyways, got to help her. So that was wonderful. But being prepared, like everything, as long as you're prepared, then it's a stress-free travel.
Okay, then, and could I get the last one of the presets, please? Will having an ostomy affect what type of work I can do? Can someone with an ostomy still work a physically demanding job?
Well, I have had a lot of patients that have gone back to work to factory jobs where heavy lifting, and I have to say they were very proactive. I think even in the pre-op part, that was their major concern. So we talked about the hernia belt to start out with. So they were getting prepared to be measured for that right after surgery. So yeah, welders. One of the jobs that I find is the hardest on people are truck drivers, because they're using their abdomen all the time. So I get lots of truck drivers, and I suggest to them at the pre-op to definitely get fitted for a hernia belt or an abdominal binder before something happens. So yes, I've had professional athletes. So that's pretty that's pretty physically demanding also. And, you know, the stoma caps that we showed earlier, those are fantastic. Gives you some level of security too, that, you know, potentially the stoma is not going to get injured.
Okay, so now I've got some live questions from folks on the webinar, so we're going to switch over to those. Someone's asking, are there ostomies that blow out/up if traveling on an airplane? Like, does pressure play an aspect to that?
You know, I've talked to so many patients over the years, and no, but there are things that you can do to prevent it from happening. And so a couple tips that I've gained, and I'm gaining all this knowledge from the patients that I see. I don't have one myself, but sometimes what people will do is they will get a piece of toilet paper, 3 or 4 little squares, crumple it up and put it inside the pouch. So that allows some air to be to stay in it as opposed to being sucked out. And so that has been something that is quite valuable. The other thing you can do is you can release air very easily. If you feel that you're accumulating too much gas in the appliance, then definitely you can just release. At the top, there's a little release button. You probably want to go into the washroom because it'll smell a little bit. And you can get rid of the air, no problem. Did that answer the question?
I think so. If it doesn't, someone might come back with a follow-up later. I do have another question here about whether or not there's a higher chance of a C-section for clients that have a stoma.
Higher C-section. I've never heard of that.
Or maybe that's one we might have to follow up with and send
Yeah,
an email out to folks
absolutely.
afterwards.
I'm going to look that up. That's interesting. I've never heard of that.
Okay. And then another one is someone was asking if there's any prevention strategies for avoiding a blockage.
Yeah, so some of the things that we discussed, staying away from those high fibrous foods. And if you think you're going to be at risk, just small meals frequently throughout the day. So and then you're going to chew your food really, really well. Typically, I'll say don't drink with your meals because it'll just flush everything through. But if you feel you're going to have some kind of a blockage, you can have something to drink at the same time. So I think chewing your food and choosing the proper food are probably two of the most important things. I mean, I can remember one young guy who ended up with an ileostomy, and I went through all the diet and we talked about everything. And his first meal home was chicken wings, Caesar salad, and a jug of beer. He enjoyed it immensely, but he ended up with a food blockage. You can imagine why.
Wonders, right?
Exactly.
Okay, and then our next question is sort of a follow-up to your presentation. So someone said, you know, you talked about nutrition in the case of ileostomies, but what about in the case of a colostomy? Are there any restrictions specific to that one?
You know, if you had any kind of problems with certain foods beforehand, probably you will have the same problems. But otherwise, unless it's diverticulitis and you want to avoid nuts and skins and things like that, a colostomy diet is basically your regular diet. That's why it's really important to know if you're going to be having a colostomy versus an ileostomy, because the diets are completely different. And yes, you should be able to eat whatever you would want to eat.
Okay. And then our next one is someone says that they've heard kidney stones are common for ileostomy patients. How likely is that?
Haven't heard about that.
Okay, well,
have to look at that one too.
we'll throw it on the list with the C-section question. So someone was asking if it's possible to relocate an ileostomy back to a location that was previously used. So if someone had one and then it's removed, is it possible to go back to the same place?
Well, mainly because of the scar tissue.
Mm-hmm.
If you were going back to the same location, I can't, unless there was another area that they could move it over, so that it wasn't directly in the same location, just because I'm not sure with the scar tissue if they would be able to construct the stoma there.
Okay.
I wonder if they've been relocated twice now.
I think that might be getting a little specific, so we might have to follow up with that one at another time as well. So someone's asking, how can you wear pants with an ileostomy? Does the pouch go under or over the belt?
The pouch would go under. And actually, I've had many patients over the years that wear skin tight clothing with an ileostomy. I actually had a model at one time, and I met her in the mall, and I was with my kids, and they said, does she have a pouch? And I said, yes. There's no problem. The stool will still get through. So yeah, there's no issue.
Someone else is asking about bleeding in the post-op. So someone's specifically saying, like, how much might my stoma bleed right after it's been put in?
Okay, well, when the nurse or yourself wipes the stoma post-op, or even once you get home, there's typically a little bit of blood on the cloth that you're wiping. If the stoma was bleeding profusely, so I have had patients that have been changing their appliance, and I hope you can see this. So the backing is quite plastic. So the one patient actually slit the stoma, and so she was bleeding profusely because she had cut the stoma. So she called and I said, just grab a handful of ice, and she put it on it and it stopped it. But fresh post-op, it should just be a minimal amount of blood on the cloth, just because the stoma is like one big blood vessel. But if you're seeing a lot of blood, that's not normal.
That might be a time to go to the ER and get that checked out.
Or use the ice.
That too, that too. Someone's asking, and you'll excuse me because I have to read this one directly to make sure I get it right. What is the likelihood of having to have an ostomy with a resection of a foot of the ilium, including the ILLEOCOCAL value?
Ileocecal. That's pretty specific. I'm sorry.
Okay. Then we can put that one off for another time.
I'd love you to send that one to me, though.
I will do that.
Thank you.
And
Sorry.
then someone else has asked, do you have to protect the stoma when you're showering or bathing?
Absolutely not. Ideally, you want to get into the shower without the appliance on, soap and water, no problem, as long as it's all rinsed off completely. No, you want to get in, and like I said, it's kind of like washing your backside. There's nothing sterile about it. There's nothing you can do to harm it. I mean, yes, if you rubbed it really, really hard, it probably will bleed a fair amount. But if you're just washing it normally with a soft cloth, everything should be perfectly fine, and you can shower whenever you change the appliance.
Sort of the end of the questions I have. I'll give people a couple of seconds to sort of speak now or forever hold your peace. This is the last chance to put stuff in, and if not, we'll start wrapping up. Okay, someone's asking Teresa if you're specifically located in Ontario.
Yes, I am. Whitby, Ontario.
And one last one we've gotten in is someone's asking if there are any programs that offer 24-hour support by an ostomy nurse.
Oh gosh, wouldn't that be nice? To be honest with you, it's hard even through the home care to get us authorized to go out, because I think they might think we're too expensive. But to be honest with you, the sooner the ostomy nurse can get to the patient, the sooner they get on the road to back to the next chapter. So I wish there was. I really wish there was. But if you reach out quite often, we can conversate via email also. just, yeah, that would be really nice.
Got another one here. Does the heat that comes from like a sauna or a hot tub affect pouches?
So yeah, it does, but it shouldn't prevent you from going in. Quite often, the patients that I see that are going to be using a hot tub or swimming or showering, because a lot of people shower every day with the appliance on. Sometimes what they'll do is they'll picture frame around the appliance all the way around with like a cloth tape, just to give it a little bit extra support. And then once they're finished, they'll just take that off and blow dry it or whatever, towel dry the area. Should be perfectly fine.
I think that wraps up the rest of our questions. So if I could have the slides back. Oh, they've already jumped ahead. They're so good at this. So now that this is done, we have a second poll question for you. You should recognize it. It's exactly the same as the first one. How would you rate your current knowledge of ostomies on a scale from 0, not at all knowledgeable, to 10, extremely knowledgeable? All right, so it looks like we had some numbers move in the right direction, which is always great for us to see. And I will ask us to move to the last slide while I do my wrap up. So thank you all so much for joining us. If you have any more questions, anything pops into your head, or you require further support, please email learn@crohnsandcolitis.ca and we will try our best to help you out with that. Next slide. Also, please let us know how we did and what you'd like covered in future events. It should take about 60 seconds at the end of this presentation to provide your feedback. A prompt to complete the survey will appear on your screen directly after the event, and we would really appreciate it if you could fill that out. So then, last but not least, thank you all so much for attending tonight, and I hope you all have an amazing rest of the evening.